Let me take you through a clinical scenario. Now, this scenario is about an 18-year-old boy, and this 18-year-old boy complains of right-sided nasal obstruction, okay, since the past 1.5 years. And that obstruction has been worsening over time. Now, this child also has a complaint of on and off nasal discharge, and since the past 1 month, he's been noticing a kind of mucoid discharge coming out from his right nostril. Okay, so I've got two important symptoms. One is right-sided nasal obstruction that has been there 1.5 years, and then mucoid discharge, which has been on and off. But since the past 1 month, he has this mucoid discharge from his right nostril. Once he sleeps, the father says that this child also has a tendency to have snoring and mouth breathing. So now I have got a lot of symptoms that are opening up. I take a further history of the child, and he tells me that he also has on and off allergic episodes. Now, allergy means, in a layman language, that he has got watering of eyes. Sometimes he has got running nose. He sneezes a lot. So now I have something in mind that this might be related something to allergy. So I do a diagnostic test on him. That is a diagnostic nasal endoscopy. I try to see inside what's there inside the nose. So I find a deviated septum that is quite mild towards the right side. And then when I go inside, I see something gray and shining. Now, always remember this term that I'm telling you. Something gray and shining and globular, I find right there inside the nasal cavity. So now I am a little inquisitive to see what exactly is this gray, shining, globular mass that is there inside. So I take a Jobson-Sons probe inside my hand, and then I poke it. I just enter the nasal cavity on the right side, and then I start to move the Jobson-Sons probe all around that mass. Now what happens is, I ask the patient, do you feel anything? He says no. That means the first thing I get is, this particular mass that I'm feeling is insensitive to touch. It is insensitive to pain. Okay, that means he's not at all experiencing any kind of pain when I touch the mass. The second thing I ask, that do you feel that this mass has grown over time? Okay, do you feel that sometimes it comes out of your nose? So he says, yes, on and off, I see something grayish at the brim of my nostril, and suddenly I sniff it back, it goes back. So now he gives me this history when I see this mass. Fine, now I have to confirm my diagnosis as to what exactly this mass is. So I go forward by doing a scan or a CT scan of the paranasal sinuses. And then I see that there is a huge hypodense area that is present in my right maxillary sinus. And that hypodense area is coming into the nasal cavity. So now what is my diagnosis? That means there is some pathology inside my right maxillary sinus which is coming out inside into my nasal cavity, and that is the reason which is producing that nasal obstruction as well as intermittent discharge. So what is that? One of the commonest things that comes as a question to you, as well as the most common things that are found in a population. And what it is? Nasal polyps. So this is a very important question for you. This is a high-yielding question for you and the most scoring. I'll tell you, because of the fact that this has got no rocket science behind it. You can answer this question plainly and simply, and you can, you don't need to learn this topic up. You can think and you can figure out the answers within it. Okay? Because of the very simple type of presentation these people give. And this presentation is not going to change from person to person. It is going to be the same. This polyp is going to look the same in every person, and even the clinical scenarios are going to be absolutely the same in every person. That is why you never confuse when polyps come. Okay, so let's dig into what exactly nasal polyps mean. Now, whenever we study any topic, okay, we first have to figure out what exactly do they mean, literal meaning of those things. So when I'm talking about polyps, what do you mean by a polyp? What do you mean by a polyp? Polyp means that it is something that is hopping out of the mucosa. Okay, so I have a normal mucosal lining. Okay, so suppose this is my nasal mucosal lining, or suppose you say this is my sinus mucosal lining. And sinus mucosal lining means that this is the mucosa that is above the sinus cavity. Okay, this is my sinus bone, and this is the mucosa that is covering over the bone. Okay, now when I tell that this mucosa hops out, it just hops out or pops out, it will be called as a polyp. So similarly, I use the term what? Hop. That means my mucosa is going to hop out. So how it's going to hop out? If it becomes hypertrophied, if it becomes edematous, and if it prolapses out. Simple. So this is how you can learn the definition of polyp. If the normal sinus mucosa hops out, or you can say if the normal sinus mucosa becomes hypertrophied, edematous, and prolapses out because of an underlying allergy, infection, or inflammation, it is given the name as polyp. Simple. So this is something like a hop out phenomena that is happening to a normal mucosal lining, which influenced under allergy, inflammation, or infection is hopping out from the normal variant wherever it is existing. So if it is inside the maxillary sinus, it is hopping out of the maxillary sinus, entering into my nasal cavity. That's what I'm meaning here. So this is the hypertrophy of the epithelium, edema of the epithelium, as well as the prolapse of that mucosa. That is given the name as polyp. Okay, so that you need to know. So basically, before moving on to a polyp, you should know what exactly polyps are. Now, polyps, as per the reading goes, can be divided, and this is the way we are going to read it, into two broad types. Now, these types are not only just by the way the polyp presents, it is also on the basis of age group of presentation. It is also on the basis of how the pathophysiology of their presentation is. It is also on the basis of in whom they present. So basically, these types can be broadly divided into two broad categories. One is a type of polyp that is called as an antrochoanal polyp, and the other one is called as an ethmoidal polyp. These are the two broad areas where we can divide these two kinds of polyps. So what we are going to do, we are going to take them one by one, okay? And we are going to see how they happen. And then we are going to make a diagram. We are going to simplify them by making a diagram and making the symptoms in the diagram. And then after that, we'll treat it. Similarly, we'll read the ethmoid. We'll make a diagram of the ethmoid and we'll try to figure out what exactly and how the ethmoid polyps occur. Fine. So we are going to make things simple by just dividing them and reading them separately. That's what we are going to do. So now we know what exactly a polyp means. Now we are going to first go into the first type of polyp, that is antrochoanal polyp. So you can get any of these questions. If you get a nasal polyp question, then you have to write both of these entities. If you get a question of antrochoanal polyp, then you just have to write this antrochoanal element. Okay, so now I'm going to tell you about antrochoanal polyps. Now, it is also given the name as Killian's polyp. Remember that. So there are two names to it. It is also called as Killian's polyp, also called as AC polyp or antrochoanal polyp. Now break this term into two. Antro and choanal. That means what? This is a hypertrophied edematous prolapsed mucosa from the antrum of the maxillary sinus, which grows towards the choana or the posterior choana. Simple. Use a hop and put it in the antrum and choana. Simple. That's called as antrochoanal polyp. Right? So basically, it has got two important elements. It is coming out from the antrum of the maxillary sinus, and then it is growing into towards the posterior choana. So first, we'll need to know what is the site of location of this polyp. So it hops out. Now you know the literal meaning of hop, okay? Of the antrum of the maxillary sinus. This only occurs in the maxillary sinus. Never confuse. Antrochoanal polyp is not an ethmoidal polyp or it is not a sphenoidal polyp. It is purely from the antrum. That's why it's called as antro and choanal. So it's from the mucosa of the maxillary sinus or from the antrum of the maxillary sinus. And then it grows towards the choana. Okay, fine. Now let's make a diagram. So suppose this is my diagram of the nasal cavity. This is my septum. This is my turbinate. Now, we have discussed much in detail about the osteomeatal complex. I'm not going to go into the osteomeatal complex. This is suppose your middle turbinate. And this is the area where my maxillary sinus is opening. This is my opening of the maxillary sinus. Okay. Now, because of some infection, inflammation, and allergy, okay, this normal sinus mucosa became hypertrophied and edematous. Okay, this became hypertrophied and edematous. And now it prolapsed out through this maxillary sinus ostia opening and it came into the nasal cavity. Okay, and then it will grow backwards towards the choana. So basically it will grow back to where? It will grow back towards your nasopharynx. So this is your eustachian tube and this polyp is going back and it is going to be like a mass like this. So this is something which you see anteriorly. Okay, so what I'm saying right now, this polyp is growing backwards, not ahead. It is growing backwards. Now, there's a reason why it grows backwards. First, what exactly I mean by this diagram? If you see this diagram, this particular antroconal polyp has got 3 parts. So now I'll do second point, parts of antroconal polyp. What are the parts of antroconal polyp? One is in the antrum. Okay, so this is called as the antral part. One is coming into the nasal cavity. This is called as the nasal part. And one is growing backwards towards the posterior choana. This is my nasopharynx. Posterior end of my choana. I'm seeing the eustachian tubes opening of the both sides. This is called as the choanal part. So if suppose I'm taking out an antroconal polyp from a nose, I have to address each and every part separately. Otherwise, I'll leave a part of the polyp inside that will regrow. Okay, always remember that. So this is how usually this particular parts present. They have got 3 important parts. Okay, now I'll get back to what I was telling. Now, what exactly is the age group of presentation? So this is usually a younger age group problem. It usually occurs in younger people more. Male is more than females, okay? And this mostly is associated with concomitant allergy. So those people who have younger allergies, okay, they have a lot of sinus inflammation that is happening at the young age. They have got this prolapse of mucosa that is usually seen in the male age group. That's why I told you a history about an 18-year-old boy who has come with right-sided nasal obstruction and associated on and off mucoid discharge. So now you can figure out how this has become, how this is. And when I saw the nose inside, I saw a gray glistening mass that was present inside. I'm going to tell you exactly why this is gray, why it is glistening. But just remember, it is inside in males more. Allergy is the most important factor which causes this antroconal polyps to happen, and it is mostly in the younger population. This is a very important epidemiological information because when you see a case, whenever you are getting clinical scenarios, if you get a unilateral nasal obstruction with a mass in a younger age group, always think of an AC polyp. Ethmoidal polyps are usually an older age group and they are bilateral. They are usually unilateral. Okay, so always remember this particular data, what I'm telling you. Okay, so now this is what the general thing about antroconal polyp is all about. Now I told you a very important point. This polyp is not growing anteriorly. This polyp is growing posteriorly. That means it is going backwards. Now, why is it going backwards? Why not anteriorly? It's this reason for it. And what is the reason? What is the reason behind formation? It all lies in your embryology. Now just imagine, when my cilia or my mucociliary clearance is happening, my cilia are like this when I'm breathing. So my cilia are beating backwards. And that is the reason my polyp also tends to get shifted backwards. Point number 1. So one is my cilia beat backwards. That is the first point. That's why this antroconal polyp grows towards the choana and not towards the anterior choana. It goes towards the posterior choana. 1 point. Second point. Your nasal cavity, if you see, it is not like this straight. It is bent behind. So my nasal cavity has an angulation which is present posteriorly. So it is the bend of nasal cavity posteriorly. That's another important point. Okay, that's the second point. Third, how does your air current grow? It goes backwards. So my air currents are growing backwards. So these are the 3 important points where you should know that why your antroconal polyp is growing towards the posterior choana and not anteriorly. 3 important points. Why? My cilia beat backwards, my bend of my nasal cavity, floor that is posteriorly, and even the air currents grow backwards. So that is the reason my antroconal polyp also grows backwards. Okay, so this is just for your information because of the fact you will get a choanal part in this, and that is why I need to tell you why exactly things are happening backwards. Fine. Now you have known what exactly the antroconal polyp is, in whom it is occurring, what is the reason it grows backwards, what are the parts of the polyp. Now let's come up, important, why does this polyp occur? So there are certain theories of antroconal polyp or AC polyp. Now, what are the theories of antroconal polyp or the AC polyp? Okay, so I'll tell you there are many theories, but I'll tell you 2 important theories. First is Proet's theory, and the second is Bernoulli's principle. Now, what exactly do you mean by them? Fancy terms, very easy to learn, because they will tell you exactly why these AC polyps are happening. Okay, so what I'll do now is I'll make a sagittal section. Okay, I'll make a sagittal section. That means I'll just cut the whole section of my head like this. And I'm going to draw it. So this is suppose your sagittal section. This is your nose. This is your upper lip. This is your floor of the nose. This is your back. Okay, this is your palate. This is your sphenoid sinus. This is your superior turbinate, middle turbinate, inferior turbinate. Okay, this is how the sagittal section looks like. Now suppose, okay, just imagine what happens in Bernoulli's principle. Bernoulli's principle is basically a principle of physics. Okay, it states that whenever something passes through a narrow chamber, the pressure at that area drops, but the velocity of things increase. So suppose if something is traveling from a bigger chamber into a narrow constricted zone, what will happen? The pressure in this area of the narrow constricted zone will become down, as well as what will happen? It will have a higher velocity. Okay, that means my negative pressure will build up. Okay, there's no positive pressure. My negative pressure will build up at this particular area. And the velocity of things will increase so that they can cross to the opposite side. That is happening in a narrowed cavity. Now, for example, take for AC polyp. Suppose this is your turbinate and this is your septum. This is your maxillary sinus. This is your middle turbinate. Okay. Now what happens? Whenever we are having air currents, our air currents are going through a narrow cavity like this. Through this narrow cavity. Again, through this narrow cavity. So what is happening? My pressure at this particular area is dropping. My velocity is increased, but my pressure is dropping. There's a lot of intra-negative pressure that is building up inside this area. So what will happen? This negative pressure will suck in all the mucosa more. So it will suck in all the mucosa more. And that is called as Bernoulli's principle. That means whenever there is something that travels through a narrow passage, the pressure drops, velocity increases, the negative pressure that builds up will suck in the normal mucosa, and that will prolapse inside and can initiate a polyp formation. Okay, so that is one reason that has been postulated by Bernoulli's, quite commonly used in understanding why AC polyps happen. Otherwise, we have got no reason. If suppose this hypertrophy or an edema of the mucosa is happening, it should stay within the sinus. Why it is popping out in through the opening inside into the nasal cavity? So it has to be sucked in into the nasal cavity, and that is the reason why Bernoulli's principle comes into play. Okay, that is. So point number one, you understood why AC polyps happen because of Bernoulli's phenomena. Because there is a lot of negative pressure that happens to get at constricted sites, and this sucks in the mucosa, it prolapses out, and then it becomes edematous and hypertrophied and grows backwards. And you know why it grows backwards. That's Bernoulli's phenomena. Now let's come to the second one. Second is called as Proed's theory. Proed's theory states that during embryogenesis, there is faulty development of the maxillary sinus ostia. So there is faulty development. It doesn't develop properly. It is wider. Okay. And that is the reason once this faulty development happens, whenever there is a prolapse or a mucosa grows through it, okay, it prolapses out generally through this faulty development of the maxillary sinus. So this states that there is faulty development of the maxillary sinus ostia. That means my ostia is not very well formed, okay, and it has got a faulty development, and that is the reason my mouth of the ostia remains open and everything prolapses out through the existing ostia easily. That is called as Proed's theory. And what is Bernoulli's? This is the most important phenomena you should remember when it comes to AC polyps. Done? Now you understood? So now we have done exactly why AC polyps happen, what actually are the principles or the theories behind AC polyp formation, and how actually they present. Now I'm going to tell you exactly what are the symptoms of AC polyp. Now for the symptoms, I'm just going to take this diagram and I'm going to draw a huge diagram of a person who presents with AC polyps, and you are the one who is going to tell me exactly by this diagram what will be the symptom. I don't need to go into any details of learning because I don't want to mug up my symptoms. I want to just clarify what exactly these symptoms are. You can easily do that. Now suppose this is a maxillary sinus ostia of this particular person, and there's a huge polyp that has come up like this, and you see this kind of a mass like this. Okay, fine. Now you tell me what exactly will be the symptoms of this kind of a person. So we'll first think. This is my one side of the nasal cavity. Suppose I'm standing in front of you like this. This is my right side. This is my left side. So what will be my first complaint in here? Definitely, I don't have any space to breathe. So my first will be unilateral nasal obstruction on towards the right side. Point number one. Okay. Do I have any space in which I can clear my discharge? Or sinuses will keep draining my discharge, right? When the sinus drain that discharge, that has to go. That has to drain off. Because of this polyp, will my sinuses get any space to drain their discharges? No. So what will happen? It will keep collecting here. And that is the reason you might get confused, because you might, when you see the nose, maybe on anterior rhinoscopy, you might see just discharge. But once you suction this discharge out, you will see this gray glistening polyp behind. So always remember that whenever you have got unilateral nasal obstructions, never leave the patient without clearing the discharge. You might find a finding behind it. You might miss out on a polyp. Okay? You might think it is just a rhinosinusitis or with a discharge. So let's give a rhinosinusitis treatment. You might send the patient on some antibiotics and antihistamines, but you might miss out on the polyp behind. So always they are associated with discharge, which is camouflaging the main area or gray zone which is hiding behind. Okay? So always remember that. So this person will also have unilateral nasal discharge. Absolutely fine. Okay. Now, what is the other symptom? This polyp is there since a long time. It will grow backwards towards the choana. Okay. Will the person be able to breathe properly? No. So he will have breathing difficulties. So once he has a nasal breathing difficulty, what will he breathe from? He will breathe from the mouth more. So there will be mouth breathing. Correct? Then after that, what will be the next symptom? If you see in this particular case, this is growing backwards. Okay. Now, something is called as that this choanal segment, once it grows back, can it cross to the opposite side? Absolutely yes, because it's growing back into my choana. So this is my eustachian tube opening. Once my antrochoanal polyp grows backwards like this, it can come back to this side also. So it can cross to the other side. So this polyp can also give bilateral nasal obstruction. So you might get confused that you have a polyp on the right side. But why do you have bilateral nasal obstruction? Because of the fact that this is growing towards the choana, or a posterior choana. And behind that is my nasopharynx. So behind, when it grows into the nasopharynx, it can cross towards the opposite side and come to the other side nasal cavity. That is why they may also present with bilateral nasal obstructions. Another important point. Does this person has any space to get olfactory stimulation? No. For an olfactory stimulation, you need that particles of odor to go up to the roof. Now this blob is sitting right there. It will trap every odor particle on top of it. Will that happen? Will you get an olfactory sensation? No. So they will present with what? They will present with hyposmia, bar anosmia. Correct? Okay? It's very, very simple. You think what all can happen. Fine. Now, once a polyp has been lying down for a very long time, this is there. What will happen? Secondary inflammatory changes started happening over the polyp. So now when my polyp is lying down for a very long time, dry air currents are hitting it again and again. So what will happen? There will be secondary inflammation that happens over on the polyp surface. That means that will get angry. Now my polyp is angry. Okay, so it is secondarily inflamed. This secondary inflamed polyp can also produce episodes of bleeding that is called as epistaxis. Definitely it can produce epistaxis, or it can produce, once it bleeds out, it can definitely cause epistaxis because now it's angry, it's inflamed, correct? Okay. Now let's come to the other part. Now this polyp can grow in any possible direction. It can grow outwards, right? Because it has to fit into this space. Now it is already full inside. Okay, it has come into the nasal cavity, it has gone behind. So what will happen? This person will have a push over his cheek because his polyp is full inside. In huge polyps, it is full. So now his cheeks will have a pressure. So he will experience pain and pressure over his cheek region. So there will be pain and pressure over this cheek area because the maxillary sinus will be full of that polyp. Another important point, okay? This polyp can also produce headaches. because now it is going up. So suppose if it's going toward the roof of the nose, then definitely this person will also complain of headache, on and off headaches. Right? See, it's so simple. You just have to think this particular scenario in which you have to make one diagram and think where all the polyp can go, what all can happen. Now, this polyp is growing backwards into the nasopharynx. Okay? What is important here in the nasopharynx? Eustachian tube. Eustachian tube opening will get blocked. So what will happen? Because of the eustachian tube openings will get blocked, they will produce otitis media with effusion. Right? So what will they present with? They will present with hearing loss. Now you see one particular condition of the nose is having an ear condition also. So how important this is to address at the right time. Correct? So now these are the common symptoms which a polyp can produce in front of you. And you can present with a patient in which any of these symptoms can be there. It's not like every polyp has these symptoms. But these symptoms can be overlapping in any possible person. But all of them fit into this possible criteria that this is an AC polyp. Okay. Now, always remember, I told you the causative factor for this is allergy. So they will have allergic related symptoms too. So allergic related symptoms mean they may have watering of eyes, they may have regular sneezing, they may have regular itching inside the nose, a sensation of clearing the nose again and again. Okay. So all of this is all related to AC polyps because allergies come with AC polyps together. Remember that. Okay. This is done. Now, if this polyp becomes too big, it can even hang down into the oropharynx. That is a very rare scenario, but still you can have that if the person has not addressed it on time. So it can even hang down into as an oropharyngeal mass. So you might get confused that this is something like a tumor, but actually it is not. It might be the AC polyp which has occluded the whole of the nasopharynx, occluded the whole of the other side of the nasal cavity, and it is hanging down into the oral cavity as a huge mass. Okay, so it has got an oral component sometimes also, which comes out into the oropharynx. Okay, so always remember that. That is in very extreme cases. But these are the usual symptoms of antroconal polyps. Okay, how it presents. Fine. Now we'll move on to exactly seeing the signs. And then after that, we'll see the management of antroconal polyp, and that's done. So now we'll see what are the signs of AC polyp. Now, here I'll tell you an important test because this is something that is asked, how to differentiate a polyp from a turbinate and how do you basically tell a polyp, like you examine a polyp. So suppose you see this kind of a polyp that is present here. Okay, so how will you examine this particular case? So first thing you have to tell that I'll do something called as a tip elevation test. So first, starting from how do you examine the nose? First, you will start from the external framework. So you'll see the external framework of the nose. Okay. Then after that, you'll see the vestibular area. You'll see the vestibule of the nose. You'll see the columella of the nose. Then after that, you'll put your thumb and you'll elevate the nose. That's called as a tip elevation test. So the tip elevation test will tell you exactly whether there is caudal deviation of the DNS or not. We have done that. What is caudal deviation, what is not. Then after that, you will use your speculums. That can be a Vienna speculum or that can be a Thudicum's nasal speculum. And you will put it inside the nostril. Now, the speculum has to be held by the non-dominant hand. So if I'm using, why I'm using the non-dominant hand for the speculum? So that I can use any of my things or my instruments by the dominant hand. If I want to do something, I want to take a biopsy, I want to suction the discharge, I can use my dominant hand. So the speculum always is in the non-dominant hand. So suppose I'm standing in front of this patient, okay? I use the speculum of my non-dominant hand. I see first the right side of the nasal cavity. Then I move towards the opposite side. I open my speculum. I see the left side of my nasal cavity. Now, once I see the left side of my nasal cavity, I see a gray glistening mass. Okay, so now how do I describe a polyp? Now I'm going to write it for you. So now you have to describe a polyp. You will say, I see a gray glistening mass, okay, which is roughly globular in shape, which is extending. Now, how much centimeters it is behind the vestibule? That you have to tell. So polyps are usually at the level of the turbinates, okay? So this polyp roughly looks like that it is around 0.5 centimeters from my vestibule. So I'll say it is 0.5 centimeters behind my vestibule. So this is how you need to describe a polyp, and this is how I'm telling you. This is a general condition in which you have to describe. Suppose you get a polyp case, this is how you describe a polyp. Okay, so it's a gray glistening mass globular in shape, 0.5 centimeters behind the vestibule anteriorly. Anteriorly is the vestibule, right? Anteriorly. Then it is medially extending up till my septum. Laterally, it is extending up till my inferior turbinate. Superiorly, it is extending up till the level of middle turbinate. And posterior cannot be made out, because of the fact that posteriorly it might be going into the corner, so I cannot make out with my anterior rhinoscopy. Now you understand how do I describe a polyp? How do I examine a polyp? This is how I describe a polyp. Whenever there is a nasal mass, this is how you describe it. Okay, you have to define these where it is above, below, anteriorly, posteriorly, medial, lateral. How much is, what is the color? It's glistening or not? What is the shape of that roughly? So this has to be defined. Okay, now I know this is a mass. Now how will I know this is a mass and not a tumor or anything else? So now I'll do a specific test. So what is that called? That is called as a probe test. Now, what do you mean by a probe test in polyps? Okay, what do you mean by a probe test? So what I do in a probe test, I'll take something called as a Jobson's horn probe. So Jobson's horn probe is like this. It has got a ring end and it has got a serrated end. So I'll use what? Which end I'll use for examination of the polyps? I'll use a serrated end. Okay, remember that. So basically, now I'll put a cotton bud on top of it, like this. Okay, and I'll use this end to basically examine inside. So this is called as a Jobson's horn probe. Now what will I do? Now I'll take the probe and I'll put it inside and I'll touch the polyp. I'll see the first sign. First, I'll see whether the polyp is sensitive or not. Usually polyps are not sensitive to touch. Then I will see whether the polyp bleeds on touch or not. Usually they do not bleed on touch. Only if they have secondary inflammatory changes or they have inflammation on top, then they will have bleeding. Okay, so that is an important point. And the third will be, I have to pass my probe all around. So what is the difference between a polyp and a turbinate? So this is a common question that is asked to you in Vivas. Okay, that's why I'm telling you. So once you're doing this probe test, this is how you'll define whether it is a polyp or it is a turbinate. The point one. What does this look like? This is gray and glistening, right? So polyps will be gray and glistening. Turbinate will be pink in color. Okay, that's the first point. Now, polyp, if you touch them, they will be soft to touch. But they will be hard on touch. Right? Will the polyp bleed? No, the polyp does not bleed. There's no bleeding. But a turbinate has got a lot of supply, so it will bleed. Okay, on touch. When you touch a polyp, you won't find any pain in that person. So it is insensitive to pain. But this will pain because definitely it has got a lot of nerve supply. Anterior ethmoidal nerve is supplying it right away. Okay, so this will be sensitive to pain and touch, right? Then after that, what will be the next part? That if you see a polyp, it will be smooth. Okay, it will have a smooth surface. So there will be a smooth surface over the polyp. Okay. Then after that, if you see the other part of a turbinate, it will have a kind of a bossylated surface. Okay, it will be a rough surface that you will see. So this will have a rough surface over the turbinate. Right? So these are the gross differences in which by looking at that, you can tell that whether it is a polyp or it is a turbinate or by touching it. Now an important point. When I'm passing the probe or my Jobson's horn probe around the polyp, I will be able to pass it all around like this. Because obviously my polyp is coming right from behind my maxillary sinus and it is coming anteriorly and then going posteriorly. So I'll be able to pass my probe all around the polyp. But you see this inferior turbinate, it is attached to the lateral wall. Now if I pass my probe, I will be able to pass it downwards, medially, upwards, but not laterally. That is the difference. So in my probe test, I will not be able to pass my probe laterally. It will get stuck. In case if it's a turbinate, I will be able to pass the probe all around if it's a polyp. Remember that. Okay. So whenever you have been asked, what is the difference between a polyp and a turbinate on inspection and palpation, this is what you have to tell. Very, very important, high yield question in Vivas. Always remember, this is where maximum students go wrong. Okay, so this is what you need to know. Whenever you're examining, I won't even go into ethmoidal polyps because you will, in ethmoidal polyps, this is the same thing. The only thing is it will become bilateral and it will become multiple, like a grape. But you have to describe each and every part of ethmoidal polyp separately. Where it is extending, how much it is extending, what is the extent, medially, laterally, upwards, downwards, how do they look, what is the surface like, whether they how will you differentiate whether from it's a turbinate or a polyp, whether they bleed, whether they're not, sensitive to touch. All of this comes together and it's the same. What I am doing now, same thing you put into ethmoidal polyp, bilaterally it's the same thing. Okay, it's not got anything different. But your technique has to be right. Okay, now does your examination end in here? Absolutely not. So you have to do a very important part. What is that? Posterior rhinoscopy. Why I'm saying posterior rhinoscopy? Because you have to see the nasopharynx also, right? Your nasopharynx has the choanal part that is going back. Okay, so you need to see whether your eustachian tubes are fine or not, or whether the anterochoanal polyp has gone totally back and it is seating there. So definitely the nasopharyngeal part has to be seen properly, and that will be in your posterior rhinoscopy. That's a very important investigation here. Okay, so now you know exactly what it's all about. What is the AC polyp like? How it comes into being? How do you examine an AC polyp? And how do you basically go forward in working up a case? Now is just the management of AC polyp. So let's see the management of AC polyp. Very, very simple. So first is investigations, definitely. What investigations you would like to do in this? So my first investigation that I like to do will be looking inside the nose. That is diagnostic nasal endoscopy. Fine. So I'll do a diagnostic nasal endoscopy. I'll map the extent of the polyp, okay? And I'll see where all it is extending. I'll see the opposite side of my nasal cavity too, because in some cases it might turn and get into the other side. That's how in DNA I'll find it out and map the extent of where it is. Then, second, if there is any mucoid discharge that is coming from the nose, okay, I might have to take a culture sensitivity to find whether it is infected or not. That is one thing I can do with the discharge. Third thing I will do will be an imaging. Now, imaging can be an X-ray, where I'll see a sinus cavity which is totally opaque. So I can see a maxillary sinus opacity, which is completely opaque. Or I can do a simple CT scan of paranasal sinuses, where I will see a hypodense mass filling the whole of my maxillary sinus cavity, coming inside my nasal cavity and going into my posterior choana. Okay, simple. Basically, CT scans and X-rays are just modalities to help you understand the extent of the disease, nothing else. Okay, they are just going. AC polyp, you can just see and tell that this is an AC polyp. These are only the investigations which you will be requiring during surgery, because you need to know each and every part, where it is going, how much it is going, to plan your surgery inside your head and how to take it out. Okay, so that is the only role of these things. Otherwise, they are not diagnostic. Otherwise, maximum diagnostic happens just by seeing it. Right? Fine. So these are the three main things we will like to do in cases of whenever we have polyps. Now, fourth can be an adjunct to allergic testing. So I want to do an allergic testing to find out the source why this polyp is happening in that person. So allergic testing means I can go for a certain thing called a skin prick test. Okay, why is the person allergic to? Okay, or I can go something called as a radioallergosorbent assay. Okay, so this is also a newer technique in which I can find out base immunoglobulin E levels as well as absolute eosinophil counts. So these are all the battery of tests which are required for allergic testing. Absolute eosinophil counts will be raised. IgE levels will be raised. RAST skin prick test will basically tell me what is the allergen and why it is happening, because it will happen again if I'm not taking out the causative agent. So this is for seeing the polyp. This is particularly for finding out why the polyp happened. Okay, my allergic testing, that is just for an adjunct. And definitely I'll do my routine investigations in this person because he has to be worked up for surgery. So whenever you're writing, how will you manage a case? Try writing why you're using these investigations. One word. Routine investigations to work up the patient for surgery. These investigations to find the source of allergy. These investigations to map the extent of the disease. Simple. Okay, now I'll go for the treatment. So treatment is very simple. Wherever you get an AC polyp, take it out. Okay, so if it is a small AC polyp or if it is only limited to your nasal cavity, a part of your choana as well as your maxillary sinus, you can easily take out with endoscopic sinus surgery. We call it FES. We have done much in detail what exactly we mean, and we do it under GA. So that's called as functional endoscopic sinus surgery. We are retaining the function of the sinuses and taking out the polyp or the pathology. If it is a very huge polyp, okay, it's occluding the whole of your maxillary sinus, then in that case, we might not be able to take out the whole of the polyp, because sometimes we might just leave behind a segment. It might just pluck off, and we might leave a segment behind hiding in the maxillary sinus. Okay, in those cases, if the segments are hiding behind, I will try to do a Caldwell-Luck so that I can directly visualize the sinus cavity, and I can take out and cure it out the whole of my polyp, and I can send it for histopathology. That is the reason I use a CT scan. So if it is involving the floor of the paranasal sinus, if it is involving the roof of the maxillary sinus, those are difficult areas to access with your endoscope as well as your instruments in FES. Right? So in those cases, I might choose an adjunct Caldwell-Luck, in which I gave a sublabial incision. I can go, I can see my sinus, I can visualize my polyp extent, and I can curate it out from the wall of the sinus. And finally, I can close that cavity. And we have done how we do the Caldwell-Luck operation much in detail separately. And we have also done much in detail what FES means. So I'm not going into that, how we do it. But this is the two options in which we can address the polyp out. Done. So now we are done with exactly how do we treat AC polyps? How do we manage these particular conditions when it comes to antroconal polyps? Now I'll move on to the second segment of polyps, that is ethmoidal polyps. So I told you already the major story. In ethmoidal polyps, I'm not going to go into all the things that I told you, how to examine a polyp or what do you mean by examination. I'll just go and highlight the points, what is the difference between an antroconal and an ethmoidal polyp. Okay, so the same sequence we'll now follow. The first thing what we found was that where does the site of that polyp is. So when it comes to antroconal, it was in the antrum. Ethmoidal, you will get the name. They are happening in the ethmoidal sinuses. That is why the site of predilection of this particular polyp is ethmoids. Okay, that's why they are called as ethmoidal polyp. Now, how do they present? How do they present? So they present in mostly the mid-age group or older people. And they are also more in males than in females. So this remains a common part. So this is usually in the age of 45 to 50 years. Okay, 40 to 60 years of bracket. Median age is around 45 years. But younger population will have AC polyps. So here only you get the differences. It is occurring in the ethmoids. That is occurring in the antroconal part. This is occurring in the mid-age. That was occurring in the younger population. Both are more than, males are more than females. Now, then we did the causes. So what were the causes of antroconal polyp? It was usually recurrent allergies, okay, sometimes infections. But what are the causes of ethmoidal polyps? There is a mnemonic to that, okay. So there are many C's and A's, okay, so you can remember like that, how I remember. So I'm going to give you a small mnemonic to remember the causes of ethmoidal polyps. What are they? Number one, you can remember the C's, okay. First I'm telling you the C, what are they? So C is chronic rhinosinusitis, one of the very common causes. So recurrent episodes of chronic rhinosinusitis can cause hypertrophy of the mucosa over the ethmoid sinuses, and that can prolapse out. One. Then comes the second one, okay, after chronic rhinosinusitis, ciliary disorders. Now, what do you mean by ciliary disorders? There is a very important syndrome that is called as Karategnas syndrome, which is basically nothing. It is a ciliary dyskinesia. My cilia do not beat properly. So because my cilia is not beating properly, my mucosa is going to prolapse at that point, okay, and it is going to hang down. Okay, because my cilia is not motile, it is not working. Okay, it will get inflamed, my mucosa will get inflamed and it will hang down from there. It won't move anywhere. Okay, so that's basically in Karategnas syndrome. That is ciliary disorders. Then comes the third reason. Third reason is Churg-Strauss syndrome. Churg-Strauss syndrome. What happens in Churg-Strauss syndrome? The same thing. Ciliary motility is lost. So that is why everything stagnates there and that prolapses out and that causes a polyp. So basically this is the rule of stagnation because my cilia are not motile. They are not getting that mucin or any collected thing backwards into the nasopharynx. Everything is getting collected there and it is prolapsing. That is called as Churg-Strauss syndrome. Now comes the fourth one. Okay, what is the fourth one? Fourth one is cystic fibrosis. Cystic fibrosis is the most common cause of polyposis in children. Okay, it is a mutation that happens in CFTR gene or cystic fibrosis gene. Okay, so that also basically is a channel. A CFTR gene is basically a channel. Okay, it is a sodium chloride channel that is not formed properly, and because of that, there is a lot of stagnation that happens in there, and because of that stagnation, they present with recurrent polyposis. Remember that. So all of these C's are related with polyp formation. Which polyp? Ethmoidal polyp formation. Now I'll tell you certain A's which contribute to ethmoidal polyp formation. Now I'll come to the A part. Okay. So what is the first A? So first A is asthma. So always remember, allergy is a unified airway disease. It doesn't happen only in the nose or only in the upper airway. It has to be in the whole airway. So the lower airway allergy can also lead to upper airway allergies. And that is the reason asthma can also lead to polyposis. Remember that. Okay? Asthma. Mostly it is a childhood asthma, okay? And they usually become polypoidal by the time they become adults. Okay. Now comes the second A. Second A is allergic rhinitis. So those people, I told you it is a unified airway disease. So definitely those people who have allergies of the lower airway will also have allergies of the upper airway. So allergic rhinitis can solely be responsible for ethmoidal polyp formation. We come to the next A. Allergic fungal sinusitis. So always remember, fungal infections inside the nose always present in 80% of the times as polyps. So if you are asked a one-word answer, in all of these conditions, which is the most prominent condition for causing polyps, more than 80% of ethmoidal polyps are because of allergic fungal sinusitis. That is your one-word answer. Okay, the most important condition for causing nasal polyposis bilaterally as ethmoidal polyps is allergic fungal rhinosinusitis, also called as AFRS. Okay, this is an important high-yielding question. Remember that. One important condition, maximum cases come with this. Okay, this is about allergic fungal rhinosinusitis. And then comes the last one, that is aspirin intolerance. And what is that called as? That is called as Samter's triad. Okay, so this is also an important question. Samter's triad, three things. Aspirin intolerance with nasal polyps with asthma. These three things constitute the Samter's triad. Very important part which constitutes with nasal polyps. If a person is aspirin intolerant or NaClide intolerant, he will also have nasal polyps. Remember that. Okay. So there's a huge condition. But how to remember them? Remember 4 C's and remember 4 A's. Okay. So this is how basically you can club up what are the causes of ethmoidal polyps. So this is how the scheme. We went in antroconal and this is the same scheme we are going in ethmoidal polyps. Fine? Right. Now we come up to the easier part. Symptoms. Now these are bilateral polyps. Always remember they occur bilaterally because ethmoids are involved bilaterally. So they are not one side, they are both sides, they are bilateral. Now whatever I told you in the symptoms of antroconal polyp, put them the same here. So it is the same symptoms as antroconal polyp, but all of them, you make them bilateral. So if I told you unilateral nasal obstruction, make it bilateral. If I told you unilateral nasal discharge, make it bilateral nasal discharge. Okay. All things that I told you, make them bilateral. Simple. Okay. This is how we make things simple. Now comes the signs. Signs I already told you. The same scheme we'll follow. First, we'll inspect by anterior rhinoscopy. Then after that, we palpate. Palpation is by probe test. Probe test, I told you what to do. What is the difference between a turbinate? What is the difference between a polyp? How will you exactly define a polyp? Everything has to be the same. The only 2 points in signs that you need to remember that will add up extra in here will be what? The signs will be that they will be bilateral and there will be multiple polyps. So they will give a grape-like appearance. They will have a grape-like appearance. They will have multiple types of polyps like this. So they will have a grape-like appearance, unlike the antroconal polyp, which was single and pedunculated. So they will have a grape-like appearance. So they will be bilateral and multiple. That is one point that you will add. Same way you have to describe as I told you. How far is from the vestibule? What is the size of the polyp? What exactly is the shape of the polyp? How many polyps can you see? What is the color? Where all they are extending medially, laterally, up, down? Everything is the same. No difference. And one more point that you have to add. The second point is whether there is associated broadening of the nose. Broadening of bridge of nose. So what happens is, if suppose you have polyps on this side and this side, sometimes if they grow constantly, they can widen this intercanthal distance. Now this is my intercanthal distance. They can widen it and both my canthi can go away. Okay, so this usually gives me a certain deformity that's called as a frog face deformity. Okay, so if both of my external, ethmoidal polyps are extensive on both the sides, they will increase my intercanthal distance. That's called as broadening of the bridge of the nose. That is an important part. Okay, it will flare up the bridge. These are the only 2 signs that you have to add. The rest of all, everything is the same. Now see the magical part again. Now come to investigations. Same investigations that I told you as in case of AC polyp. Same thing you put in here. Same investigations. No change in investigations, same way. You have to work them out. Okay? And then comes what? Then comes the treatment. Now what is the line of treatment? What we did there? FES under GA. Definitely yes, we can do FES under GA. But like that, if it is a big polyposis, we are not able to clear it, we can also do something called as external ethmoidectomy. So we externally place an incision over the ethmoid and we do an external ethmoidectomy. So see, in ENT, the major part lies in just learning one topic and the other topic automatically comes to you. It's not about mugging up the sequence. You can just think and close your eyes and think of the symptoms. And finally, we have everything we have to take out. So surgery is all about taking out everything in the end. So just take it out. If there's an ethmoidal involvement, take out ethmoidectomy. Simple. Okay, we do it by an external approach, so that's external. There we did Caldwell-Luck because it was a maxillary sinus. FES remains the magical point in every case because this is one surgery where every nasal condition can be treated. So FES definitely will be my first line of action. If not, then I can go for this. Done. Simple. It is all the same and same way we need to work it up and same way we need to answer it. So if you learn one, automatically the second one becomes easier for you. Fine. And you clearly know what is the difference because we have been doing it in the same way, defining one and then comparing it with the second one. That is what the difference is all about. Fine. So I don't think so there is anything required to remember now because this is something that you can just visualize inside you and you can write your answers. Easy topic. So now what is a polyp? I told you something that hops out. It is hypertrophy edematous mucosal prolapse that happens from the normal mucosa because of an infection, allergy or inflammation. Okay, remember that. Antragonal polyp, I told you, Killian's polyp, they are arising from the maxillary ostia. What are the theories? Two important theories. Bernoulli's phenomena, I gave you an idea what exactly you mean by Bernoulli's and what is Proed's theory. So I told you that exactly how it happens is because of constant allergies that are happening in childhood and associated infections that happen in childhood are the reason for AC polyps. So there's allergy plus infection in childhood, AC polyp is the answer. Clinical features, I told you it grows backwards. Why does it grow backwards? I gave you the theories. Put a diagram and correlate the symptoms. I always say that. So always draw a diagram and explain your answers on the diagram, just as a simple diagram. And it's very, very simple to make a triangle and a white color blob inside it. It's very simple. So you can just explain by the help of diagram and correlating the symptoms. Treatment is simple. First line of action is under GA by functional endoscopic sinus surgery. Big polyp, go for an external approach by Caldwell-Luck. Clear the sinus off. Ethmoidal polyp. What is the difference? They are bilateral and they are in adults. Now here, majorly, what are the causes? There are 4 C's and 4 A's. So I've told you what exactly is the mnemonic and you have to remember that. Okay. Now what are the clinical features? Clinical features, again, draw a triangle, correlate with diagram. But the only difference will be, this is single and pedunculated, this is multiple grape-like and bilateral. That is the only difference. Other than that, all things are the same. Treatment, yes, it also is FES. Otherwise, sometimes you can also do an external ethmoidectomy if it is a huge polyp. Difference between AC polyp and ethmoidal polyp, we have been doing since the beginning. We are taking one, comparing it with the other one. So in the end, you can just think what all differences. For differences, always remember, if you miss out on the sequence of events, you just have to follow the sequence. Right from epidemiology till treatment, follow that sequence. If you break that sequence, you'll forget that what is the difference. So always follow that sequence and then write. So if you come to symptoms, then symptoms are almost, one is unilateral, one is bilateral. If you're thinking of signs, it's unilateral signs, bilateral signs. If you're thinking of epidemiology, one in younger people, one in adult. When you're thinking about with sinuses involved, one is maxillary, one is ethmoidal, right? This is how you never break the sequence. Once you are not breaking the sequence, you will get your answer on your own. Okay? Because you know already the topic, whole topic in and out. Fine. So this is about all that you require about nasal polyps. Very important Viva question. This is an important case scenario that is given to you in your examination. So always learn this topic well. Okay. These are the common things that are asked in the Viva. The most common fact that is asked in the Viva is the difference between the two polyps, as well as how will you examine in the probe test, or how will you examine a polyp. So that has to be on spot. What exactly is the difference between a turbinate and a polyp is also very important. So these are one of the commonest questions that are asked in Vivas, as well as small MCQs can come from this topic. So this is all about nasal polyps.